Despite multiple conversations, multiple appeals, the health insurance company ultimately decided that they were not going to approve the services for this particular patient, who ended up a short time later in the emergency room due to suicidal ideations.
Hello, and welcome to Disruptors at Work, an integrated care podcast. Today, we'll be discussing the recent news related to rampant insurance claims denials and the impact this industry behavior has on our patients. Hello, and welcome back to Disruptors at Work, an integrated care podcast. I am Dr. Cara English. I am the Chief Executive Officer and also the Chief Academic Officer at Cummings Graduate Institute for Behavioral Health Studies. And I am excited to welcome to the podcast today Dr. Heather Jelonek. She is a graduate of the Cummings Graduate Institute's Doctor of Behavioral Health degree, and she has also joined our faculty now to share with our students all of her many years of expertise, in addition to her Doctor of Behavioral Health expertise as an executive in the insurance industry. So Dr. Heather, welcome to the podcast.
Thank you. I'm excited to be here.
Yes, and so we've kind of connected over an article that you shared with me via email, and the article is, I'm just looking at my notes here, I just want to get the date right. It was published on January 17th in ProPublica, and the article is called "The Impact of Insurance Claim Denials for Mental Health Treatment." We will share the link to the article in the show notes. Maya Miller and Dua LD, pardon me for the poor pronunciation on that last name, talked about the experience of a healthcare provider responding to a very common issue in our professional lives, which is claims denial. So, Dr. Heather, can you talk a little bit about some of the key points of the article that really stood out to you as a DBH or as a person who's been through this many times?
Absolutely. I think the number one facet of that article was the absolute trauma that not only the clinician experienced, but also the patient. The clinicians were doing everything that they felt they could within their power to make sure that this patient received the benefits that they needed or the services that they needed in the most appropriate setting. And despite multiple conversations, multiple appeals, the health insurance company ultimately decided that they were not going to approve the services for this particular patient, who ended up a short time later in the emergency room due to suicidal ideations. So it's a perfect example, I think, of what every American experiences in today's health insurance and healthcare delivery system environment, where their treatment protocol, their hope, their wishes for the future are in the hands of someone who is not directly involved in their care.
Absolutely. Having been through that many times myself, I can definitely say that it is traumatic both for the patient who is worried about, being able to get the care that they've been getting ongoing, with the same provider. It's also very traumatizing as a provider to feel like, in our training, we many times have been through a refresher. Every single time we update our license, we have to go through our ethical guidelines for practice to make sure that we're doing our due diligence to provide the care at the standard of care. And we know that at any time, should we lose a patient to suicide, which is the thing that all of us get into this field to prevent, but, should that occur, that we would be, subject to a real strong review of our records to make sure that we were doing absolutely everything we could, not just to care for the patient, but also to collaborate with other care providers to, reach out for additional support or a higher level of care if that individual becomes suicidal. And so for any of us to be in that care episode, to be denied the opportunity to continue that care, it's such a break of trust with the provider and the system of care that we're all paying big dollars to sustain, the insurance industry. So I know on the other hand that, you know, so often people say, well, it's a business. They've got to run a business. And so I want to ask, do you see ways that the insurance industry could better align incentives so that cost efficiency and high quality patient care don't feel like opposing forces, so that we're not continuing on in this cycle?
Yes, absolutely. Um, the principal area that I think needs to be focused on is primarily how ill a patient is, right? We always talk about
Mhm.
comorbidities or chronic medical conditions in addition to their mental health or behavioral health conditions, because we know those go hand in hand.
Mhm.
And when insurance companies are out and they're bidding on business, Medicare Advantage, for example, or Medicaid Advantage, they're looking at how sick a patient is. So, how
Mhm.
many chronic conditions does that patient actually have? And then they're using that information to send it to CMS, to send it to HHS, to demonstrate that they're taking care or they're insuring a sicker patient population.
Mhm.
The higher the patient's risk adjustment score, the higher the level of reimbursement that the insurance company will actually receive from either the states or the feds.
Mhm.
However, what doesn't happen is the clinicians who are treating that patient, the complexities, the comorbidities, they aren't appropriately reimbursed for how sick the patient is. When
Mhm.
you look at a standard fee schedule for a general office visit or a general therapy session or even a hospitalization, there are only certain things that are taken into consideration. One primarily is a history and physical. Two
Mhm.
is the skill required. And then three is the
Mhm.
time that the clinician is actually spending with the patient. If
Mhm.
we start factoring in how sick the patient is and increasing clinician reimbursement accordingly, we're going to
Mhm.
have better outcomes. The
Yeah.
other issue, of course, is that many of the insurance payers today are publicly traded. So the decisions that are being made are about profits and shareholder success.
Mhm.
There are a few exceptions to that rule. Obviously, Blue Cross Blue Shield is a non for profit. However, they still have reserves that kind of defy logic, and they have more
Mhm.
money in their reserves than they actually need under state and federal law.
Okay.
So we need to be balancing patient care, physician engagement with shareholder expectation. And in
Right.
fact, we're starting to see some of that. One of the major payers has recently been under scrutiny by some of their largest shareholders about wanting to know about prior authorizations and denial of care and mortality outcomes when patients didn't get the care that they need. So when
Mhm.
Wall Street and investors start pushing back and demanding answers and demanding accountability, I think we'll start to see some more
Mhm.
change in the industry.
Yeah. So I want to unpack a little bit of that risk, that calculated risk adjustment for the insurance company. How much of the provider who is doing the care, how much are they involved in calculating that risk?
It depends. There are in the Medicare space, for example, there's something that's called the Medicare annual wellness visit. And that's the opportunity for the patient to come in and the clinician goes through all of their chronic conditions.
Mm-hmm.
So, hypertension, hypercholesterolemia, diabetes, depression, anxiety, bipolar disorder, they're documenting all of that information in the patient's medical record. Then
Mm-hmm.
that information gets sent to the insurance company, whether it's United, Aetna, Cigna, Blue Cross, Centene, it doesn't matter. They all do the same thing.
Mm-hmm.
Then the insurance company will send that information to CMS to adjust what they receive per patient or for that
Mm-hmm.
particular patient's care.
Okay.
Some of the insurance companies have hired external vendors where it's not the patient's primary clinician who's actually
Mm-hmm.
performing this risk assessment. It's someone that the insurance company has hired to go into the patient's homes most often and collect this information. having run both an insurance company as well as an ACO, I've seen
Mhm.
some of that data come back where, patients are supposedly being diagnosed with both stage 1 and stage 2 or type 1 and type 2 diabetes.
Hmm.
And when we look at the patient's medical record, there's no indication in the patient's medical record that they have type 1 and type 2. So,
Wow.
where the information is coming from is a challenge. And then, whether or
Mhm.
not the patient is actually receiving care, excuse me,
Mhm.
receiving care for all of those diagnoses that have been submitted to CMS and HHS
Mhm.
is at this point a huge gap. Patients
Yeah.
aren't necessarily receiving the follow up for those diagnosis codes. So, are
Mhm.
they really appropriate? Are they really
Right.
accurate? Or is this just some information that someone collected and sent?
Okay. And that I think is where the trust piece gets so difficult
Mhm.
because, patients are paying, or, knowing that their tax dollars are being used to fund their insurance care,
Mm-hmm.
and they're seeking care in good faith. The vast majority of folks seek care in good faith with the understanding that they have a contract with the payer to reimburse for the care that they're receiving. But for patients, it is feeling more and more difficult to get that care. And when they've been told by an insurance company, well, you need to talk to your provider because they didn't bill it correctly. I was a provider who received that message from patients. I had patients who called me, emailed me letters that they were getting, and it had absolutely nothing to do with anything that we were doing on our end, anything that I was doing as a provider. And so there were times where I had to actually get on the phone with the patient so that we had, both of us there with the billing assistant so that we could, everybody in the same room, get on the same thread, try to find somebody at the insurance company who would sort out the problem with the claim so that it could be paid.
Yes,
Because there were times where we submitted 5, 6, different episodes of care, and we were getting denials. And so after a time, most clinics have a policy that balance goes back to the patient. And so a
absolutely.
patient is then being hit with a huge bill saying that they owe hundreds of dollars usually, or sometimes thousands
Mm-hmm.
of dollars, because the insurance company isn't paying for it. So then the burden comes back to the patient. So it's this, cycle of not my problem, not my problem, not my problem. It's very
Exactly.
stressful for everybody. Like you mentioned, to go back to the trauma word that you used, it is traumatic
Yes.
for everybody.
Yes, because everyone believes that they're doing everything that they're supposed to be doing. In 99% of the instances, they are.
Mm-hmm.
They're, over the course of the last year or so, we're seeing a number of lawsuits that have been filed, class action lawsuits that are being filed against the major insurance company for inappropriate use of AI,
Mm-hmm.
where AI is deciding whether or not a claim, quote unquote, meets the requirement. And then it is a physician who ultimately hits the denial button. But
Mm.
according to a number of these lawsuits, these physicians and clinicians who are supposed to be reading medical records are, in fact, not.
Right.
Between the time that the claim file is sent and the time that the clinician hits deny, there's no
Mm-hmm.
time to review hundreds, if not thousands, of pages of patients' electronic medical records. So
Unbelievable.
it is. It's absolutely frustrating, and that's even if you can get someone on the line at either the
Yeah.
customer service or the provider service number, without dealing with, again, AI that
Mm-hmm.
isn't fully educated enough to be able to answer a lot of these questions. And
Yeah.
patients and clinicians alike will end up throwing up their hands and simply paying the bill or
Mm-hmm.
writing the bill off. And the insurance
Right.
company then no longer has fiduciary responsibility to pay a claim.
Yeah. And in your experience, I'm just curious because, unlike many other doctors of behavioral health, you have direct experience, as an executive in the insurance industry. And so often I think we think of executives in the insurance industry as, money grubbing, they don't care administrators, who are just there to, make profits for their shareholders. But in your case, that's obviously the opposite of the case. And so I'm just curious, within the executives, within your experience, Tell me a little bit about the perspectives and the pressures, that healthcare insurance executives face, and what they do to try to find some balance between cost containment and ensuring patients, do receive high quality care.
And you're right, it is an absolute struggle. Having run a health plan, when you're looking to sell products on healthcare.gov, ACA, Obamacare, whichever phrase you prefer, it
Mhm.
is about trying to get to the lowest price point, the lowest monthly premium with the richest benefit plan, right?
Mhm.
Making sure that preventative things are covered, that prescription drugs are covered, the whole 9 yards. A lot of that's mandated by the ACA, but some of it's just good business practice. And
Mhm.
with the escalating costs of the healthcare delivery system, it is a challenge, but there are, from my perspective, a whole heck of a lot easier ways to address some of those cost challenges that have nothing to do with the unit you pay or the unit price you pay for an office visit. A
Mhm.
perfect example is when I was working at the particular health plan, we had an exorbitant amount of money going out of network. And
Mm.
what I found after, doing some digging is that we had physicians on our network who were taking our patients to non-contracted facilities, non-contracted
Mm.
hospitals, non-contracted ambulatory surgery centers.
Mhm.
And the challenge was that these physicians do have multiple hospital privileges or ASC privileges, and they just didn't know which hospitals or which ASC they should be taking their patient to. So I actually put a
Right.
process in place that every single request for a prior auth at an out of network hospital came to me. And then I
Mm.
worked with our care partner to say, this patient needs to go someplace else. And we were able to save a couple of millions of dollars over the course of about 18 months. That didn't
While ensuring that the patient still got the care
ensure
and that the provider
exactly.
was still directing care, but it was just making a better choice.
Exactly, about the place of service.
Mhm.
Another is place of service. I know, having been on both sides of the equation in health insurance, I've
Mhm.
worked on the provider side, hospital side, as well as on the payer side. Having educated conversations about benefit plan design is
Mhm.
another key way to reduce spend, reduce cost without impacting care. And that is
Mhm.
making sure that the patient gets services provided at the most appropriate setting. And I
Mhm.
struggled with this with some of our pediatric patients at
Mhm.
one of my jobs, where the patients' families wanted those kids to go to the children's hospital for services, even though they weren't necessarily required to be performed in the children's hospital. So it was
Mhm.
working with some of the payers to say, let's redesign the benefit plan so that there's no deductible, or it's a very low deductible if a patient or their family chooses to use an ambulatory surgery center or a GI
Mhm.
suite,
Mhm.
versus going into a higher cost of setting. And you can
Yeah.
do that. You can change patients' behavior simply by adjusting their financial responsibility. And then
Right.
obviously, if it was a high risk case, you would always want that patient to be seen, in the hospital. But these are
Right.
things that really don't, they, from my perspective, they actually improve quality of care because you're not
Mhm.
worried about hospital acquired
Right.
infections, and things of that nature, and you're providing it in a lower cost setting. So,
Mhm. Mhm.
that's another easy option. A third easy option is, what are you doing with your pharmacy benefit management program? Are you
Mhm.
truly covering the right drugs at the
Yeah.
right level, or are you excluding medications because somebody doesn't want to give you a rebate? And that's
Right.
what happens in the pharmacy benefit space. And we're seeing a lot of that in the news as well, as
Mhm.
Congress is
Mhm.
looking at PBMs.
Yeah. Can you explain what that terminology means, please?
Oh, sure. A PBM is a pharmacy benefit management
Mhm.
program, and they
Mhm.
literally are the middleman between the insurance company and the pharmacies.
Mhm.
And what will happen is those PBMs, pharmacy benefit management companies, they come up with a list of drugs that are covered under their plan. That's called the formulary. And then there are different levels to the formulary. So you'll have generics, preferred generics, and then you might have not preferred generics, and then you might have brand names, and then you have specialty drugs. And the drug falls into different categories, and then that impacts like how much you pay for a copayment or how much you pay for coinsurance. But what I teach in one of my classes and what I do every day and what I see as a healthcare consumer is the cost of the medications, out of pocket costs, may not really equate to the benefit or the level that the formulary places that drug in. So a perfect example is I take a medication for epilepsy, and my copay for a drug that's been generic for almost 30 years is $60 a month for a 30-day supply.
Geez, that's high. Whoa.
It's high. I have since gone to use Mark Cuban Drug Company because a 90-day supply through his company is $27.
Interesting.
So that $180 that I would pay through my commercial insurance covers over a year of medication with the Mark Cuban Drug Company.
Wow.
So, just because a drug is generic doesn't mean that it's going to be placed in that lowest benefit level.
Right.
What the PBMs will do and the insurance companies will do is that they will negotiate with certain manufacturers to get what's called a rebate, where if their physician panel prescribes, we'll just say 10,000 of this particular drug, the PBM and the insurance company get a rebate back from the manufacturer. So it's not just about the lowest cost medication that's clinically effective for the patient, that's safe, that isn't toxic. It's about who's going to pay what back in terms of rebates, and then who gets those rebates. Again, this has been in the news where employers and the insureds aren't necessarily receiving those rebates back.
No. And that's something that you and I talked about long ago. I remember one of our conversations about that. And that was definitely a learning experience for me. You educated me on that too. Very interesting. So I'm just thinking of, the most patients would have no way of knowing any of this information. And most providers don't also get trained on this information. It's, these are sort of the insider info only of the insurance industry. So let's talk a little bit about, negotiating those contracts, because one of the things we seek to do at Cummings Graduate Institute as an employer is try to, as you said before, find the lowest premium plan with the richest benefits. But it's not always easy to do that. But when negotiating contracts with providers or health systems, what are usually the biggest sticking points in your experience?
There are two, and these are issues that actually make it to the news media. One, good, bad, or indifferent, is usually price. There was a recent negotiation here in Phoenix where a major hospital left a major payer and was out of network for about 5 months. And the issue was twofold. As reported in the paper, the hospital was requesting an $80 million increase in rates over 3 years. And the insurance company offered, I think it was 43 million or 53 million, something like that. And when you think about the size of a hospital, $80 million is nothing in terms of a rate increase. It's less than the consumer price index. It's probably about 3%.
Whoa.
The bigger issue with this particular hospital was the fact that they were never going to see even the dollar amount that the payer put on the table because of things like prior authorizations, denials, recoupments. And one of the conditions that this hospital had put on the payer was that they wanted an unaffiliated physician. So it wasn't a physician who wasn't affiliated in any way, shape, or form with the health insurance company to be looking at patient medical records in the specialty at which the patient's care was being provided before a denial could take place.
Uh-huh.
So, having a brain surgeon or a neurosurgeon reviewing neurosurgery claims, what
Mm-hmm.
often happens in the prior authorization and denial process is that it's not a physician who is the same specialty as the
Mm-hmm.
physician who is providing the care, or the
Mm-hmm.
physician is retired and hasn't been in
Yeah.
practice for quite
Oh,
a
yeah.
long period of time, or they're not using current evidence-based practices.
Mm-hmm.
They're using something that the insurance company designed. A lot of them aren't even using Milliman.
Mm-hmm.
And they're kind of, I'm going to say, making up their own standards
Yeah.
as to
Mm-hmm.
how things are going to be processed. And then there's no consistency among the health insurance plans. So it's like everybody wants something different, which from a hospital or clinician perspective is what I always refer to as the administrative hassle factor of doing business with
Right.
these insurance companies. So
Mm-hmm.
you've got a tremendous amount of staff time tied to requesting the prior authorization, defending the prior authorization, filing the claims, defending the claims, appealing the claims,
Mm-hmm.
getting on the phone with the claims department, a physician demanding a peer-to-peer conversation
Yeah.
about, the denials. So it's no longer just about the dollar amount, the rate increase year over year. It's
Mm-hmm.
about the administrative hassle factor and how much
Sure.
that adds to the system. We're
Yeah.
also seeing a significant number of instances where physicians and hospitals are being asked to cover the cost of care for their patients. So they're
Mm-hmm.
subsidizing it. And a really good
Right.
example is around drug costs,
Mm-hmm.
where if a clinician is dispensing drugs from their facility,
Right.
insurance companies are routinely not paying what the cost of that drug is.
Right. Mm-hmm.
So the insurance company is taking the benefit of the premium dollars month over
Mm-hmm.
month, but they're expecting the healthcare delivery system to subsidize the
To
cost
bear
of
the risk.
healthcare.
Right.
Right.
And again, I think these are things that, most of us don't know about our own plans, and it makes it really hard for us. And I think in recent years especially, the idea has been that providers are somehow taking all of the money, but I think only until very recently did it come out that 90% or more of that healthcare dollar that is being consumed in terms of the premium is not going to the provider or to the hospital. It's going in payouts to shareholders.
Yes. I mean, you've got this thing called the medical loss ratio, which
Mm-hmm.
is the
Which we
amount
love to
of,
talk about at
yes, we love
CGI.
to talk about the MLR, right? Where
Yes.
it's the amount of that premium dollar that actually
Mm-hmm.
gets spent on medical care. And
Mm-hmm.
under the ACA, depending on the size of the plan and the book of business, the
Mm-hmm.
idea is that they're spending no more than 15 to 20% of that premium dollar on overhead, right? So that's
Mm-hmm.
your rent, your staff, your lighting bill, whatever it happens to be. And then the
Mm-hmm.
rest of that money should be spent on um, medical services in one
Right.
way, shape, or form. If that threshold is not met, so if a health plan isn't spending enough money,
Mm-hmm.
then they are
Mm-hmm.
required, again, under the ACA for ACA plans, to refund members.
Mm-hmm.
And a couple of my loved ones have received thousands of dollars in refunds every year because
Yeah.
their health plans aren't spending enough on care.
Yeah.
Doesn't mean patients aren't going out and getting the care, but they made these claims denied, not covered,
Mm-hmm. Mm-hmm.
um, greatly reduced in terms of modifier reduction, site of service reduction. So there is a clear disconnect when large health plans are issuing large dollar refunds every single year.
Right, right. When that happens for a particular plan or a particular payer, what kind of oversight is there in place?
There's reporting, and again, this is really ACA related plans, but there is
Mm-hmm.
reporting that has to go back to the feds on how
Mm-hmm.
much money is actually being spent, and the federal government, at least under prior administrations, was very attuned to making sure that those patients receive their refunds. But I think the things
Mm-hmm.
that I'm not seeing in the industry and I'm not hearing is why.
Mm-hmm.
Why are you issuing so many refunds year over year?
Right, right, right.
In this
And
space where people are buying their own insurance plans.
exactly. And this is something I'm so glad you brought that up. And I totally agree with you that the question does not seem to be asked or
Mhm.
and certainly isn't being answered in our markets, because as a provider what I'm seeing is that the patient's cost to the patient is it continues to go up.
Yes.
So, year over year, their copay increases, year over year, the amount that they reimburse the provider goes down.
Hmm.
It's very, very difficult to negotiate if you're in an integrated care space as a provider. It's very, very difficult to negotiate to get a higher rate reimbursed, even though what you bring to the table is of significant more value than an individual with, a master's degree.
Hmm.
When you have that doctoral degree, you bring a lot more to the table, but it's very, very hard to get any of the insurance companies to negotiate a higher rate of reimbursement for, for example, when I worked for 3 years in integrated birth center, we were able to get the results after, at the end of year one, that we had resolved 95% of all of the patients who, completed their evaluations. Did we resolve what you came into care for from a behavioral health perspective? 95% said yes. Those are results that nobody else gets. Nowhere
Hmm.
else in the mental health specialty world do you get that kind of a resolution rate. A lot of times when people enter counseling, they never leave. But, in an integrated space, when you're looking at things from a very different perspective, the value that you bring is so much higher. But we're not seeing that being negotiated. For doctors of behavioral health, it's very difficult. And it's also very difficult for the patient because, in a lot of ways, the patient is saving a lot of money
Hmm.
for their plan by getting care in an integrated setting.
Exactly.
So, just from the negotiation standpoint, what are your ideas about moving in the direction of, fair negotiations, between health systems and individual providers, or, specific contracts? And, what do you think are ways that we can find a better balance so that the patient is still at the center of care,
Hmm.
but we aren't seeing people like mental health providers in particular making the decision to not accept insurance dollars anymore due to the administrative hassle that you brought up
Right.
of doing business with the insurance industry?
That is a significant challenge, right? We've got a
Mm-hmm.
national shortage of mental health clinicians, regardless of licensure type, in the United States. And then you start to
Mm-hmm.
look at special patient populations, and that disparity gets even greater. If you're talking
Mm-hmm.
about clinicians who work with kids, there's not a lot of us. And then, of course, the fact that so many clinicians don't take insurance.
Right.
And it's amazing to me that they can and do offer a reasonable rate for cash pay patients, because they're not dealing with all of the nightmare and spending time on the phone, and their accounts receivable are outstanding 90, 120 days when their rent's
Mm-hmm.
due on the first of every month.
Mm-hmm.
But some of the unique challenges I think that are in this space, number one, is that while we have the Mental Health Parity Act that says that services are supposed to be reimbursed and judged the same way, whether you're a medical professional or you're a mental health professional, there really are no teeth in that
Mm-mm.
legislation.
Mm-mm.
So again, when I was at the health insurance company, we were looking at plan development, and one of the recommendations from our plan builder was to have a different deductible for an inpatient mental health, substance abuse,
Mm-hmm.
admission. Like, can't
Mm-hmm.
do that. It's a violation of the Mental Health
Right.
Parity Act. Oh, we can't? No, as a practicing mental health clinician and someone who is in this space, no, you can't do that. There are no fines and penalties associated with it, but hopefully there will be someday.
Right.
Um,
And
but
until
the
there are, we can expect people to not follow. I mean,
right,
unless there's a tooth, like you mentioned, in the
exactly.
legislation, then people are just going to outright ignore it.
And I think to me, there are a couple of different ways to really handle an integrated model
Mm-hmm.
that certain segments of the healthcare delivery system have adopted, grasped, and they've maximized it. And that's the way that federally qualified health centers, rural health clinics, or
Mm-hmm.
FQHC lookalikes have structured their payment reimbursements. So they're actually paid a higher rate
Mm-hmm.
than the general medical community or general mental
Mm-hmm.
health community. Um, but they're also paid in such a way that it covers a wider variety of issues.
Okay.
And that per diem, we'll call it a per
Mm-hmm.
diem, where it's, that single dollar amount that they get paid, they can
Mm-hmm.
use it whatever way, shape, or form that they want.
Mm-hmm.
And there really is not a lot of justification that needs to go behind it. I mean, you have to be ethical and compliant and all of that stuff. But
Mm-hmm.
if you're being paid at a per diem dollar amount, it's up to the clinician then to decide, or the clinical team to decide how they want to divvy that up.
Mm-hmm.
Another significant issue that I think clinicians need to be pushing back on is the lack of reimbursement for the screenings that are so critical
Right.
to what we do.
Oh my gosh, I brought this up so many times.
Mm-hmm.
So few primary care or specialty, like women's health specialty, are billing for the annual screening. And I continue on with what you were going to say, but I have a whole theory about that.
Yeah. It's like, as our clinical code of ethics says, we should be screening for generalized anxiety disorder. We should be screening for depression. We should be screening for adverse childhood experiences. We should be.
Mm-hmm.
Um, and most of us do. We are
Mm-hmm.
using those tools, and we're providing realistic, real-time data. But the insurance industry says, well, that should be part of the visit. So
Right.
we're not going to pay you any additional amount. We're starting to see this, I think, more and more with SDOH, so social
Mm-hmm.
determinants of health screening.
Yep.
The insurance companies, Medicare, Medicaid access here in Arizona, want us to be completing these SDOH assessments for the patients.
Mm-hmm.
They
Mm-hmm.
take that information, and again, they're using it to their advantage, but they're not paying clinicians for it.
Right. Right.
There are programs out for care coordination that some practices use, some practices don't. Medicare pays for them. Most of the commercial insurance does not. So
Won't.
there's
No, it's a
well-established
huge
codes,
issue in third
well-established
party.
data
Mm-hmm. Mm-hmm.
that if they simply took the payer simply took the reimbursement amounts that they're paying for the office visit and add
Mm-hmm.
on reimbursement for the screening tools,
Mm-hmm.
that would go a long way in helping, number one, to ensure, from my perspective, quality care has occurred because I've screened my patients for these
Mm-hmm.
conditions. I'm doing the every 90-day screenings to touch base on quality and are things improving? Do we need to
Yeah.
make adjustments to our treatment plan that are improving outcomes?
Mm-hmm.
Instead of all of this stuff being bundled in. And I go back to if you pay a per diem, I can do 14 screenings, but I still
Right.
get that same per diem amount that covers all of the services that I believe in my clinical judgment are necessary for that patient.
Yeah.
That is what we're not doing enough of. That is not
Yeah.
what we're not pushing back on enough.
And I want to add one thing to that because screening is so important, but we also know that screening can do more harm than good if there's no care coordination to
Right.
ensure that mental health treatment is being, aligned for patients. And so many patients who have to go outside of their specialty office, outside of their primary care office, if they're not in an FQHC or a rural health clinic to get the mental health treatment that they need or the psychiatric care that they need. if they have to leave to do that, if the care is not coordinated, or if the physician, worst case scenario, doesn't have anybody that they can even refer to, a lot of times they won't even do the screening
Exactly.
because they recognize their own liability as a provider who has identified an illness but isn't connecting the patient with somebody who can care for that illness as a part of their overall health,
Yep.
And so I think there are lots of different barriers there in the process when you're outside of the FQHC model or the
Mhm.
rural health clinic or the CCHC model, that can really become sticking points for providers when you're trying to incentivize them to do the screening, because they're saying, but it's my liability on the line and I have no way of knowing that if I screen a person and they're positive for anxiety, depression, et cetera, that they can get care in the next 90 days. There's no way for me to know that. So it should incentivize more integration,
Yes,
but it doesn't,
but it doesn't.
because
And
yeah.
it also it goes back to earlier in our conversations, the shortage of clinicians, right? The
Mm-hmm.
folks that are willing to do this work,
Mm-hmm.
and then those that are willing to take insurance.
Yeah.
I was doing a training, about this time last year, around encouraging oncologists to
Mm-hmm.
do depression screening.
Okay.
And in the enhancing oncology model, which is a federal value-based care model, that
Mm-hmm.
is one of the quality measurements. Are you
Mm-hmm.
screening your patients for depression? And if they are positive, what are you doing? What's the treatment plan?
Mm-hmm.
What have you included in your medical record?
Mm-hmm.
And the data around that shows that patients who are effectively screened
Mm-hmm.
have better outcomes, and they
Mm-hmm.
reduce the total cost of care for that oncology, for oncology services.
Even if
And
there's no indication that they were ever treated, just being screened for it has a connection to improved outcomes.
yes, because the
Boy.
patients feel that they now have a trusted advisor who's
Mm-hmm.
interested.
Mm-hmm.
So it may not treat their depression or the anxiety, but they
But maybe it's validated, maybe it's
yes,
acknowledged in a way that no other provider has done. And so they may not be receiving mental health specialty care, but there is that empathic connection, that rapport
exactly,
building that makes the difference. Very
exactly.
interesting. Hmm.
And then the thing that I always recommend back to clinicians from that perspective is, develop your network. Who is available in your
Yeah.
community? There are community health resources available. You can always direct patients back to their insurance companies to find a participating clinician. And I'll use that in my own treatment notes if it's a specialty that, I don't have I'm not familiar with, or we don't have available. I'll put in my treatment note the patient has been referred back to their insurance company for an appropriate referral.
Mm.
So that's, always an acceptable measure. And then using things like, NAMI has a number of resources that can be handed out to patients from a brochure perspective, like how to manage anxiety, deep breathing, going out into the grass, grounding, things of that nature. And those are all
Yeah,
legitimate resources that
they
can be
are.
handed to a patient.
Absolutely. One of the ones that we used to hand out, and they still do hand out at the birth center where I worked. They no longer have an integrated behavioral health clinician, but they hand out a tool called the snowball tips, which are what we used to call the brushing and flossing of mental health prevention.
Mhm.
And it's just a series of tips that go along with the letters of the acronym SNOWBALL, such as thinking about your sleep,
Mhm.
thinking about how much liquids you're taking in, thinking about, from the S in nutrition, thinking about, are you taking your omegas? Are
Right.
you getting enough breaks? Are you getting enough laughter? Things like this. The W is for walk. And so, like you mentioned, tools that are very practical, that don't take any money, that are, usable in the moment,
Mhm.
for most people on the day-to-day basis, that they may not need a mental health provider, but their
Exactly.
provider can facilitate them thinking a little bit more about lifestyle and behaviors that contribute to wellness,
Mhm.
in a way that does contribute to improved outcomes. So that makes a lot of sense.
Yeah. Yeah. And it was stunning when I had pulled together the actual statistics and shared them, and I got a lot of, jaw open. It's
Mm-hmm.
like there are a lot of ways to deal with this. And we know that with certain chronic comorbid conditions, you're going to have a higher incident of, depression, anxiety, and, a slew of others. Um,
Yes.
and because those exist, and because I'm going to say there's a small number, because there is a small number of value-based programs available out there to contract with, but that's one of the things that's being looked at, right? It's the
Mm-hmm.
outcomes, it's the total cost, and everyone's concerned about, well, how much does mental health services cost? And it's like, well, when you look at it for every dollar spent, how much money is being saved?
Saved. Mm-hmm.
Saved.
It's that long-term return
Yes.
on investment that no one ever
Mhm.
wants to look at. And I think a lot of that is, you know, again, with the way that the insurance industry, with the way that the corporate world works, a CEO's lifespan at a company might be 2 to 3 years.
Yeah.
And their goal coming in is to increase the profit to the extent that they possibly can and then kind of leave. There's not that longevity of the CEO, lifespan that you would want to see as a consumer of healthcare,
Hmm.
to be looking at quality indicators, to be looking at accountability measures, to be looking at that. What does the cost mean forever? Not just until you
Exactly.
get your next job,
Exactly.
but for the rest of my life. And so a lot of the work that I've done in maternal and infant health has been focused on investing in that dyad, improving, the attachment, the bond, the infant mental health, the adult mental health, the family mental health, early as we can possibly get it, so that the rest of the lifespan looks a lot brighter
Right.
because, of those factors, because I don't know where they're going to go next. I don't know if they're even going to have healthcare next.
Exactly.
And so some of those contextual factors you have to think about when you're calculating that return on investment. But like you said, the return on investment might be fighting with that medical loss ratio number.
Exactly. Well, and the other thing is that it's I don't think it's a well-known statistic, but it's always fascinating to me, is that years ago, like when I first started in this industry 30 years ago, um, employers would stay with their same health insurance company year over year over year. So it
Mm-hmm.
wouldn't be uncommon for a Blues or a United, Cigna, Aetna to have customers that were 15, 20 years on the books from an employer
Yeah.
perspective. That's not the case anymore.
Mm.
It
Mm-hmm.
might be 3 years, which
Right.
also
Right.
means that the
Hmm.
patients, so the employees, are also moving every
Yeah.
year to 18
Mm-hmm.
months to 3 years.
Yeah.
And
Yeah.
the focus then is no longer, this is my perspective, the focus is no longer on the total cost of care for the
Mm-hmm.
lifetime.
For the lifespan.
It is
Okay.
the total cost of care while that individual is covered under my health plan.
And so if they can average that out and they're looking at, 5 years or less, then yeah, the goals are going to be significantly different instead of
Hmm.
being, trying to get um, as healthy as possible into the 80s and 90s of
Right.
our lifespan. So, wow, what an interesting point of view. Well, I'm sure that we could continue talking for the rest of the day. But since we've already had such a robust discussion here, I want to say thank you so much for joining me on the podcast today. I think we may need to have a part two.
Sounds like a plan. I think so too. There's so
Okay,
much
good.
that it is not known about this space. We all use it. We all, well,
Yeah.
vast majority of people use it. There are obviously some
Mm-hmm.
who are no longer insured or have never been insured, but understanding how to use it, how to work it from both a clinical perspective, but also from an individual patient perspective, is critical information that so many folks just don't have.
Yeah.
And that's why our program at CGI, we've developed a class around this to help
Mm-hmm.
educate, even at a basic level, how clinicians understand how this whole
Mm-hmm.
system and process works.
And it's such a value for our students to know this information. I think sometimes when they know it, they are entering the workforce as doctors of behavioral health feeling a little lonely, a little bit like the only one on the island who has privileged information.
Yeah.
But as we continue to educate more students, and hopefully as we continue to have these conversations and spread the word, we can help people learn a little bit more. I was fortunate to be your neighbor for quite some time in the Phoenix area. And so taking our hikes around the Valley Mountains and experiencing the beauty of the many trails that we hiked together, we had many conversations about this. So I learned lots and lots from you.
Yep,
Lucky me.
absolutely.
So, well, thanks again, Dr. Jelonek. It was wonderful to have you on the podcast, and let's talk about that part 2.
Sounds like a plan. Have a great day.
Thank you. On that note, I want to say a big thank you to our incredible guest for sharing her insight and expertise today. If you enjoyed this episode, don't forget to subscribe and share. Let's keep disrupting healthcare together. See you next time on Disruptors at Work.